We have among us Dr. C.S. Mani. He is a famous oncologist. He is a surgical oncologist. So he serves in Apollo Specialty Hospitals, Kumaran Hospitals in Kirpak, St. Isabel Hospital in Mylapore, Bilroth in Chennai Nagar, and he is also serving in Southern Railway Headquarters Hospital at Perambur. Ladies and gentlemen, I am leaving the dais to Dr. C.S. Mani to help us understand where all the digital going in oncology field. Over to you, sir.
Thank you very much for the kind introduction, and good morning you all. And I'm very happy to see you guys so early on a weekend to come and hear such things. Yeah. So when I was given this topic, I was wondering, why me? Like as if they diagnosed cancer in me. So that's the feeling I get when I have to talk about something which is so machine, and you're groomed up like so human. And so this conflict is the one which gave rise to several leads from which I'm going to give you certain snippets of what I feel where we are headed. So they call the halcyon era in medicine, where everybody is at peace, they are in tranquil, they are so at bliss, and suddenly they drop something called the artificial intelligence, and there is a journalist who called this as a consultant in hell. If he wanted to call this as a consultant in hell, he also adhered to certain of the advantages that the artificial intelligence inevitably provided, and that is about improvement in quality, cutting costs, productivity, eliminate diagnostic errors, and increasing accuracy. How many of you think these are not jobs that we cannot do as human beings? Let's say improve quality. As human beings, can we not improve quality? Definitely we can. And cutting costs, can we not? Yeah. Yesterday there is this Democratic Party guys warring against how to bring down healthcare costs in the US. Productivity, we can as humans. Eliminating diagnostic errors, I'm going to spend some time on that. And how many think we can't as human? We can, right? Yeah, we all believe in it. And increasing accuracy as well. So if these were the advantages that artificial intelligence were going to provide, what is it that as human beings we cannot? So we reflect on how as a human agent we tend to approach a problem. So as a human being, we have all the sensory inputs, your eyes, your nose, your ears, your skin, everything provides some input, and these are the signals that we are receiving, and somewhere in between we are trying to use certain kind of a neurophysiologic wherein we tend to think, yeah. Oh, is it? Okay, I can go on the stage. Okay. Thank you very much. So I hope I'm not blocking your view. All right. So we use this certain sort of a reasoning wherein we try to discern patterns, we're trying to assign certain labels, and then we take it to the very, very deeper level wherein we try to immute this in the cognition. And that is the very basis of how we as an agent, intelligent agent, react to an environment autonomously. Okay? So that is how we tend to do as human beings, and doctors are no different from any one of you in the crowd or any other professions. And there is always this idea about memory as memory in human being prone to failures, which is quite widely. I wake up in the morning and go to the cupboard and didn't know why I went there to find what I want to do. This is natural. I think a computer does never do this. The computer always remembers. Is that good or it is bad? In fact, the European law, European Parliament wanted to pass a law, the so-called the right to be forgotten. You guys remember? So, I do not think memory in its infallibility would ever remain the status that we always want to attain. It has to be a level, it has to be balanced. So, how we balance as human beings? We have a short term memory, we have a long term memory, and somewhere in between we tend to kind of fling both this and create certain kind of imagery, a world view that is going to be unique to us. And there can be many perfections and imperfections alongside when we construct this world view. So, they say that at the end of it all, your intelligence must be, the imagination should be the soul of your intelligence, isn't it? That is what they say. And think about a machine. They are using machine. I am sure there are somebody who is addressing in the different halls or in the same hall about how you can use artificial intelligence to do creativity in painting, in music composition, in things like that. So, could that imagination be exactly the same as a human imagination? It is a question that we need to address. So, here is the question for the day. Suppose I have a machine which can predict your death. Please lift your hands who want to know it now. I see. Reasonably good. I can see some brave souls in here. Right. So, sorry? Any form. You want suicide, you want road traffic accident, you want killed, murder, you can choose. I mean, let us say we can predict that, we sorry? Somebody else be happy. I am glad you brought it up. That's look at that. He is the eagle waiting for his prey. Typical, a vulture waiting for his prey. This is exactly, he brings about the most philosophical question that I was keeping it for the last, but thanks that you brought it up. If in our wisdom, okay, with using enormous amount of artificial intelligence, we knew that we are all made of imperfections, we are going to face such and such problem at such and such time, and we are going to die at a such and such moment, what would your role be as an insurance agent? You would choose the ones who you think you do not have to repay them at all, and leave those ones for whom you will have to be a big liability, isn't it? So, that is what this whole thing amounts to in terms of stretching artificial intelligence to go into the nuances of every detailed genomic data that we can possess, and we think that we possess blindly and wondering that environment will never have an influence on this, which is the biggest mistake we made. So, much before artificial intelligence, did we not save lives? We saved a lot of lives. We saved a lot of lives by enormous medical advances that are so alien to what artificial intelligence can ever do. So, technology as it infused into medical field, we had lots and lots of insights, we had lots and lots of improvement in accuracy, we had means to eliminate errors, etc. And so, I think the artificial intelligence is a small part of many other technological innovations that medicine has seen over the years. If you want to take an example within the experience I would had, I know only about cancer, so you don't call me a doctor because I'm very afraid if you call me a doctor because I know only about cancer. So, in my training days as a physician, you go to the ward, the only equipment we had was a stethoscope, and the rich people and the high flying people had the best stethoscope called the Lithman, bought from USA. We had a very Indian made 30 rupees stethoscope at that time, and both of us heard the same sounds from the heart, and made our own diagnosis, and n number of diagnoses will conflict. If there are 10 people, you will have 20 diagnoses, and the chief will come and say, this is the diagnosis, so all of us have to fall in line. That was in 1987, 88. Then came the echocardiogram, and suddenly in 2 years, I do not see any more cardiologists and professors sitting there and telling this is the final diagnosis, because we as interns took the patient to the echocardiogram and found that it was completely wrong. So, there was a limit to which you can kind of decipher and discern just by listening to sounds of the heart. Same is the case with the gastroenterologists. They put their hand on the tummy and say, oh, this is a classical case of tuberculosis, this is a classical case of dust and this. You had an endoscope, you know that they were completely wrong. You had many such examples. And in terms of even discovery, the very dogma that no living being can exist in an acidic environment as pH 1 or 2, and therefore, within the stomach, when a whole population was having heartburns and ulcers like that, we thought, much to our ignorance, that there cannot live an organism within the stomach which has an acid production at the pH level of 2, 2.5. Until recently, not so long ago, 20-30 years ago, there was a medical student and his professor of pathology. He always kept saying some organism in the stomach and kept on leaving it aside as it's some contaminant. Maybe these guys contaminated something during the processing of the tissue. And then suddenly they woke up and said, no, what we are seeing is real. And there is an organism which lives in this acidic milieu of a pH of 1. And so, the whole idea about how we treat ulcers changed. So is the case with all this technology, the CT scan or MRI. It has evolved every decade into several generations of it, that the vision we have through any one of the scans is no longer the same that we had 20 years ago. So, all this to do with machines which never had intelligence. They are all machines which just evolved over a period of time and gave us better and better ideas. At the same time, I should also tell you, the doctors during this era started questioning dogmas. Like I gave an example about how we thought that there cannot be an organism in an acid. We also started questioning dogmas because the so-called the big surgeons or big doctors in the world, whatever they gave as their wisdom was considered infallible, and everybody were following it around the world. I will give you this example in cancer. A lot of women are here. So, in breast cancer, for nearly 100 years, a guy called Richard Halstead said, you remove the entire breast with its surrounding flesh, and that is the only way you can cure cancer in a woman. And so, he called it as the radical mastectomy. And who is Richard Halstead? He was of course a doyen in the field of surgical oncology, and we all respect him and we adore him. But that aside, in a personal life also he had so many slumps. He became a cocaine and subsequently a morphine addict and all that, had a very bad life personally as well. But nobody ever lifted their finger to question this man's dogma that this is the only way you can cure breast cancer. Until in the 70s, I think as part of so-called war against cancer declared by President Richard Nixon, I think at that time. I think he was going through something like a 2G scandal of his days, and therefore, he to deflect put some money into the cancer research and called it the war against cancer. And luckily, there were few doctors who picked up this finance that was available and did a research. Are we doing rightly what we are supposed to be doing, and question this very basis of should we ever remove the entire breast of a lady who has a cancer which is so small. And then over 20-30 years of accumulating data, they said there is no necessity at all. whether you removed the entire breast or whether you removed only that cancerous part, means much the same. The outcomes are much the same. There was no difference in the way they succeeded, they cured, and then the way they lived thereafter. So, 30 years after this, they are announcing this in different major medical journals, and Bush comes in as president of America. Laura Bush is diagnosed as having breast cancer. He is across somewhere gallivanting, and they call him and give him the news. Sorry to say, Laura has breast cancer, and it doesn't remove her breast. And 30 years after we had the data, a president of a developed country takes the same road that we all traveled and say, get it removed. And that is how. So, it is not the question about availability of knowledge, it is also the question about acceptance, and it is a question about efficiently utilizing the knowledge. So, it is not just about generating knowledge alone. So, around this time we were getting more and more data that even though it is cancer, a much dreaded disease, we would still not sacrifice and make people disabled, mute, and unacceptable to normal living in a society. So, we evolved a lot of organ preservation kind of strategies, which included combination of multiple other things. I must tell you about the human genome. How many of you are aware of this human genome? A lot of you. Okay. So, this was a project which I should give you as an example of the highest order of efficacy. If a government announces a project, let us say we want to build a metro in Chennai, and we say we project in 5 years time we are going to finish this phase 2, how many of you believe that you are going to do in 5 years, and let us say in X amount of money? I am sure nobody here ever thinks about doing that. All of us know this. This is one sure thing we know, that it cannot be accomplished either in the budget or in the timeline that they provided. But human genome project was, thanks to this guy who called what is that fellow's name? Craig Venter, that is his name, a big disruptor. He said all these academic fellows sitting in their armchair and doing things in their own speed, I am going to crack this whole thing into a multiple parallel dimension genomic exercise, and I am going to pull out the complete sequence of the human genome. And the way he approached this like a monster, the entire academic community woke up and said, no, we can't now be falling behind, because more than half the work they already completed. And so, this is the example of one project where we completed the entire human genome sequencing in less than the time. It was slated to be completed in 2005, but it was completed in 2000, and it was completed in much less cost than it was projected. So, this is a classical example of getting a project in terms of efficiency as well as in terms of accuracy. But then what happened? Millennium 2000 is 19 years ago. They said, we know entire thing about human beings. Now, no longer can there be a disease in 20 years time. What happened? That genome is still lying cold there, and nothing happened. And we are getting more and more references about, this genome should match the European, the Caucasian match the Asian should match the African, and things like that. We are still tinkering around, not necessarily saying that it has contributed what it has promised to at that point in time. So, at the same time, cancer guys, we are not going to be left behind. Whenever there is something big, we want to always latch up to it. And so, we said, we are not only going to stop with the normal human genome, we are going to sequence all the cancers also. So, every cancer we started sequencing, whether it is breast cancer, whether it is brain cancer, whether it is stomach cancer, colon cancer, what not. We started sequencing, and in less than about 10 years, it is called the Cancer Genome Atlas project. It is a transcontinental effort, and we have sequenced about little over 30,000 cancers, and we have data lying there in about at least 12 common cancers out in the public database. One of my projects is involved in searching that for better things. Of course, technology keeps invading us. And so, right now, how do we practice medicine? If there is a cough or cold, we go to a GP, then he refers to a MD, and the MD refers to a super specialist, and then most of the times I hope we are cured, sometimes we are misled, whatever. So, that is the pattern at least. But then what we have to understand is a disease is not like a picture frame. A disease tends to evolve. It starts vaguely as something, becomes more clearer as time goes by, and then it actually leaps out of the dark suddenly when nobody can make a mistake of this. So, that is the natural history of any problem. It has to evolve over a course of time. Unfortunately, for doctors, they do not have this story about the evolution of the disease. Why? When you come and meet me for the first time, I ask you what happened. And what you are going to do is recall from your memory, okay, a month ago I was like this, last week I was like this, today I am like this. This is a recall from your memory. And how did that memory come? We went back. There is a short term and a long term, and there is something in between. You are trying to construct a worldview of yourself. The same disease that you have, the problems that you had at home, you would give one story, your spouse would give another story, and your child will give a completely different story for the same problem. Each one's constructs are different. So, that is one point, and I am going to examine you just at that 5-minute interval, and that is all I have information, and we need to make a diagnosis. So, how many of you think we are going to be 100% accurate? None at all, right? So, as much as there is going to be imperfections inlaid within this, and so now artificial intelligence is booming. People are saying that we are going to have wearable devices, something like a collar mic. I will keep talking. Years ago when the mobile phone came and this earplugs, I was wondering why are these guys talking so loudly, like mad people on the road, and then I realized there is a mobile phone and a earplug in which they are using exactly like that. Now I think the voice has changed into wearable devices, and we are all running around with certain other things which is going to constantly monitor our health. We will come to that later. So, in terms of making a good doctor, I think there are more issues than just having loads and loads of data which needs to be analyzed and churned out into something of an output. So, this is the one important thing that I wanted to develop on a bit. Like I told you, a disease has its evolution and you see a snapshot of it, but besides that there were a lot of audit that went into this, and what they found out, there is something called in the UK, they had audit of deaths and found that most of the deaths happened somewhere in the late in the night or early mornings, that is in hospital deaths. And then they found that these doctors who are there on call, they are at a stretch working for 1 week, continuous nights. And the ICU doctors, in fact, they did not even have day night, they continuous day and night, they were continued to work for a week. And then they said, okay, this is an element of human fatigue and overwork, so let us cut down to 8-hour working periods and let us get fresh brains each time. And they did achieve to some extent prevent a lot of that midnight deaths. It also means that the current generation doctors who come for training are so strict about this 8-hour, they will walk away the moment the 8th hour is done and come back 5 minutes after the 8th hour is supposed to start. And as much as artificial intelligence requires lots and lots of data to train, what is the biggest problem with the artificial intelligence? We need to provide them with a lot of data to train that machine, whether it is machine learning, whether it is a neural network, you need to train that guy. And what we need to train that guy, we need to provide accurate information, we need to give loads and tons of zettabytes of data so that it can churn something out. And here we have doctors in training who want to have 8-hour shift and then go back, spend some time in mall and then go back home and sleep. So, there is a lot of conflict in the way we are approaching medicine suddenly with a lot of this audits going on. And this is How many of you read Thinking Fast, Thinking Slow? It's a book written by Daniel Kahneman, one of our Nobel winners in economics, and it's a very sensational book to my mind. But then there is another guy who, after reading this book, went on to write that biography of the two guys who actually did all the research. One is Daniel Kahneman along with a chap called Amartya Tversky, and in doing that he arrived at this interesting thing, that the mistakes we make are not necessarily due to some idiocy or some lunacy or some kind of thing, but there is certain inherent bias as human beings in us that we like to stereotype, all right. So, they called it, actually what do they call it? They call it as a Linda project or something. So, if you say so and so of this profile person with this type of language and this type of maybe attire walks into, you can kind of sort of say, okay, this guy should be from this place doing this type of a job. This type of stereotyping is what happens in the human brain, and therefore leads to most of the mistakes, because we are not unable to do it fresh every time. We are not able to approach a problem fresh each time. So, that is the thing. So, this is how it all started. Several decades ago, you put in so many information, it will churn out one diagnosis, and then we started using better and better means of getting through this information, so that it will be more accurate, more faster, and then it becomes all jumbled up like this. And that is when suddenly people thought, oh, the machines also are working just like the human brain. And what does the human brain do? How many of you have never experienced a pain? Certainly all of us, right? So, if you had a pain in your toenail and the brain has to perceive it, do you know how much time it takes from the generation of pain? So, let us say you knock your toe on a stone while walking down this road. How long does it take to appreciate the pain? Seconds or milliseconds? Yeah. And the nerve which is there, which is conducting this pain, has to travel from the toe right to your spinal cord and pass on this information to another guy. The second level guy will carry this information all the way to the brain and hand over to another guy. It is called a place called thalamus, and the thalamic guy would analyze this data, perceive this pain, and then he will put on to the frontal cortex of the brain. And when you knock the same stone, all of us, one would be in tears, one would be laugh it off, one other person is going. So, the emotional component of that pain is overlaid in such a manner, so heterogeneous a manner, all of us react differently to the same pain, isn't it? So, this kind of a thing is what they thought the machine should also do. But then if you looked at the complexity, even right now we can't understand most of the things, and we are trying to see, they give funny names each time, they never want to say the same names. So, now it is called connectome, everything is a ohm now, I do not know why. So, genome, menome, auto. So, the connectome is the way that the brain nerves all interconnect to give out get an output. And we did this study, this was just published a few months ago, and one of the very coveted journals in medicine called the New England Journal of Medicine. And what I want you to see is here. See, chorea has some kind of movement disorder, something like Parkinson's, and delusions of familiarity, you see, there is a lot of. How many of you saw somebody and, oh, I know, met him somewhere, maybe I know him, sort of, that delusion of familiarity, vastly represented. But what is more diffusely represented is the criminality. So, there is crime, there is some kind of a mysterious person that is residing in our brain. So, in medicine we were looking at few processes. The machine learning is something we are already aware of. The natural language processing. In the natural language processing, we were involved in this. At that time I was working in Cancer Institute in Adyar, and we were involved in creating a unique oncology electronic health record module, and it was the golden jubilee celebration of Adair Cancer Institute in 2004, and Abdul Kalam was going to come, and so we wanted him to inaugurate this health record, and so we were spending days and nights in creating this electronic health record, thinking that it is going to be a panacea of a lot of problems that the institute was going through at that point in time. And what happened? The celebrations went on very well, and the system was installed everywhere. No doctor would go. I'm done. No doctor would go and use that system. Can I have 5 minutes? Yeah. Okay. So no doctor would go and use this system, because you don't want to have a patient sitting in front of you and turn to a computer and start typing things. So it's just not possible, and I can't do it even now. So the natural language processing helped in completely recording this conversation in a very intelligent manner and making it into a record, which is of course a biggest boon that the artificial intelligence provided to us. So I'm going to, because of lack of time, I'm going to wrap up with only one last thing about maybe we can finish with this mobile devices. I told you that the biggest problem with mistakes that medical community does is because having this frozen snapshot of a picture we have about the disease. So the mobile devices are trying to just overcome this difficulty. Okay, so you have a smartphone. How many of you don't have a smartphone? So it's a stupid question to ask on a forum like this. So the smartphone has in it a sensor which is going to measure movements in 3 dimensions, isn't it? It is going to give you the velocity, and is going to exactly give you the position in the geophysics. So they can use this in terms of measuring how fast you walk, how many steps you took, etc. And the microphone in that mobile phone is receptive to pressure changes. That is how our sound waves are essentially pressure changes. So the same can be used to measure your lung function, and the camera, you just have to put your finger in there, and the camera can subtly notice the changes in the blood flow and give you a heart rate. So this was amazing, because if I can continuously monitor your heart rate and I know that suddenly your rhythms are not going fine, then I can immediately make a diagnosis and tell you how to intervene with that. Not only that, in terms of continuous monitoring, they can also say, like what is called as the ecological data, that you can get a reminder saying that, oh, how are you feeling today? Are you feeling too anxious? How is the pain? Is it mild, moderate, severe? So if you have to come to a consultation, let's say 3 months later, and tell me about the same knee pain story we started 3 months ago, a lot of things would change. But instead, at every point in time, if I keep reminding and you keep logging in, okay, this is the level of pain at this point in time, at this level of activity, then I have more data to work on exactly finding out how to kind of spread your medicines, how to design your rehabilitation, etc. Lots and lots of things like this. So that's what we thought. So is the case with other devices, whether you wear something like a smartwatch, which can pick up with some sensors in it the electrocardiogram, or whether it can, there are wearable devices. People say that you can measure what kind of muscle acts in which kind of an activity and how it is trained, and etc. So all these things are great, except that somebody has to interpret it. Except that, okay, let us say we put a machine to interpret that. There must be a person who should take this interpretation and act on it, and who is going to do that acting on it. And let us say that person is he mandated to act on only that interpretation of the machine, or can he veto that machine and give his own verdict about how this has to be designed? So where are we? Thank you very much. Sorry, I skipped your timing.
Hey, no worries. Yeah. Thank you, Dr. Mani. And any questions? So we have, yes please. There are a couple of mics, so please come to one of the mics and then ask the question.
Thank you very much, Doctor. With all the due regards for your noble profession, I would like to go back to the point where you talked about the radical surgery, right?
Yeah.
So with the amount of data that we have been talking about, right, been collected for years together, where do you see that, this actually can go to a level, it can actually go to what you call a targeted area rather than actually looking at the big one. Like for example, you see there is what you call a need for the stomach to be removed because of the cancer that is actually coming up at the stage 1 or stage 2, right? So when will you see, or you're going to give the assurance, okay, as a community, right? The paradigm shift from getting a complete stomach, or I don't know how to say that, it could be stomach or breast or whatever it is, right? To a targeted place like where a small lesion will be there, and the surgery will be only confined to that and get removed. Because as you said rightly, there is enormous data which is available at this juncture, right? Like for the last 30 years or 40 years, right? So how do you see this AI is going to help you, enable you, so that people don't end up actually losing an organ, which they have been possessing over a period of time, and they also feel they are like intrinsically handicapped after that. Yeah. So how do you see that this AI is going to help that? Because like we say in the banking industry, like lenders of last resort, right? Like you are the saviors of the first resort. So how is it going to help this human being?
Excellent question. Excellent question. So it's like this. See, I am the sort of person who is already available to write the obituary of my own profession. Simple reason is, what is the ultimate endpoint of preservation of any organ? That you should never touch it. You should allow it to function as it were. Only that it shouldn't get diseased. Okay? So when it gets diseased, we are looking at, for example, in your own example about whether it is the stomach or the breast, why are we doing all this sequencing of the genome in the cancer is, we are looking for some targets which if we attacked, it is like the so called sniper shot. You just remove that guy and leave the rest of the guys undisturbed. The question here is, if not all organs, unfortunately we are not born with that regenerating capacity. So let us say half the disease, half the organ is diseased, and you eliminated half the organ. Would the remaining organ be functional enough for you to lead a normal life is a question. So we bring in the essence of regenerative medicine. Can we incorporate, see, cancer is one thing which is dividing in an uncontrolled manner. Can we reinstitute the controlled manner of growth with a regenerating ability and bring back that organ? Question is very deep, isn't it? So I should say, my sister had a transplant 20 years ago, and I happened to be the donor that time, and I gave her a survival about 5 years. Maybe in 5 years time we'll have off the shelf organs, so she can carry on, it doesn't matter. So I'll have to give her a lease of life only for, let's say, 5 years. But no, 20 years down the line we don't have that. And regenerative medicines, we had a meeting in Hong Kong a year ago, and it is still in the shape of organoids. It is not yet organs. You get the point? So that is where we are. So of course, eventually all of us are trying to get into that so called garden, isn't it? Yeah, thank you. There's another lady, can I? Okay, okay, collateral question.
Can this be an indication for preventive medicine like vaccination? You have
Absolutely, absolutely. See, vaccination did not require intelligence, artificial intelligence. Saying? For cancer. Yeah.
And say, for example, even the case of
Exactly, same question that he asked. Yeah, if you can identify, see, what is the vaccine after all is to help the immune system understand what is self and what is not self, and it has to fight what is not self. That is all it has to do. So what we do in vaccination, we actually bring down the power of a virus and make the immune system learn, if you ever see this guy, go kill him. That is what we instruct the immune system to do. So what we do in a child, we give this diphtheria vaccine, and a lifetime the diphtheria is stopped. You give for polio, for a lifetime you save them from polio, because the memory is forever. So what is the problem with cancer and vaccination? The cancer is not uniquely identifiable by one sequence of a gene. It is a multi genomic problem. Okay? In the genome, it is like haphazardly loads and loads of areas are going deranged, and there is no single point which we can choose that we can simply teach the immune system, okay guy, if you see this, knock him off. We can't say that, because different it is like a kaleidoscope of different formations in each cancer, and the same cancer is not different in the same person when it comes back or in the same sibling when it comes back. So that is the reason we are not able to pick on one thing and say, okay, knock it off. Yes, ma'am. Sorry.
Hello, doctor. I'm Lavanya. So I have two questions.
Yeah.
One is like lately there has been an increase in the cardiac arrest. Actually, it may not be due, not the cancer side, but I'm just asking the common question. When compared to heart attack, there has been an increase in cardiac arrest actually. So is there any study has been performed on that area? Like do you have any thesis been going on that area to analyze why there has been a sudden increase in cardiac arrest? Because I myself have seen this happening in front of my eyes, someone collapsing in front of us. So, so I just want to understand that one. And second is like, it can be a stupid question, but just want to understand, when we are actually donating our blood, is there any behavioral thing that is also getting transferred from person A to person B? Or is there any connectivity there? Have you done any research there?
Okay. Excellent. I'll take the second question first because not so stupid, it's real. So, in terms of transfusion, that is you donate blood and another person takes, do you also give a little bit of your soul? Do you give a little bit of your peace of a mind to that person? No, you don't. Organs is for organ, we don't do that. But there is a deep connectivity. I don't know why. See, for example, we have this organ donor register. We are not supposed to tell to whom that organ should go. Understand? In fact, this was a big conflict in the US. There was a white person who refused to give that organ of theirs to a black person. So there must be the heights of anonymity in terms of doing this philanthropic activity. There should not be any issues. So other than the fact that there must be some, see, a person who received the heart of a dead person can go back and meet their family and say thank you. The connectivity is still there. So that kind of affect will be there, but not necessarily transfer some kind of a mind related issues to another person through the blood. So that doesn't happen. For the first question, why women have more cardiac arrest? Generally, everybody has cardiac arrest. Well, lifestyle is certainly to blame. The stress involved in the current lifestyle, you can't believe how much we pack inside the same volume of time 10 years ago or 100 years ago and now. It's just not imaginable. So all these factors do play a role in our health, and heart has to be the one which has to bear the brunt of most of it. You have to, the heart pumps, like the biological clock where we know we have to die at a certain point in time. The heart cannot stop, heart has to keep beating till that death happens. Whether you are kind of an athlete or whether you are a person who is laid back. So it has to meet its demands all through one's life. And so all these environmental factors, physical, mental, everything would play a part in the cardiac disease, and of course cardiac arrests are on the rise. I would recommend that you should read a book called Deep Medicine, written by a chap called Eric Topol, and he is an artificial intelligence guy. He is himself a cardiologist, and he dwells on some of these issues that you pertinently raised. Thank you.
So last question.
Please.
My name is Govindarazu. I am looking at it from a very common citizen point of view. I don't know about artificial intelligence and natural intelligence, but the only thing what I know is we hear a lot of stories every day. Somebody is diagnosed with cancer in the third stage, fourth stage. Suddenly, it doesn't have any major symptoms all this time, but suddenly over a period of last 1 month or 15 days or 2 months, he's developed some symptoms, and then finally he lands up in an issue where it agrees with the case, stage 3 or stage 4, and he has been given a time limit saying that no, you can't live beyond this.
Done.
So with so much of advancement in technology, medicine, this, that, and all that, why is that we are not able to detect or at least find out at some point of time that there is a risk factor in this. And every time you ask a doctor, sir, is there any test we can do to find out, at least in advance? No, I don't hit a case, I'll land up in stage 3 or stage 4. No, doctor says it's all bullshit. You don't have any test which will tell you that no, this is going to come, and the tests are all complicated, never give you right results. So just be happy, don't think about anything else. So these are the normal replies we get. This is number one. Number two, is there anything, a lot of times we hear because of the lifestyle changes and the adulteration in the food, pollution, environment, all these things are causing the cancer. Is it true? What extent is that causing the cancer? So what are the risk factors where we can prevent, at least from a lifetime, lifestyle behavioral point of view? So these two are
Great.
general doubts.
Great. So to the question about why we are not able to diagnose cancers early enough when it is easily curable enough, has two factors in it. One, the nature of the disease, and two, the nature of the person. Now, when did you last have an indigestion? You never recall, right? Because it is so subtle. I mean, all of us have to go through some kind of ailment, and it is so subtle in our lives, or we keep it so subtle that we don't want to recall that at all. These are the subtle warning signs that we are supposed to pick up in order to go for a checkup. So let's say that it is humanly not possible to lend our time or years or mind to subtle changes in our own health. So at that time, like I told you, when we were doing all this research in the 70s, what happened was we moved towards a program called screening program. So we don't wait for symptoms. Okay, we just go into the community. Hearing, right? So we just go to the community, house number 1 to house number 50. Please all come out. And all the women come into a truck, and they have a certain mammogram, and then they go back. We do this every 2 years, every 3 years. So in the process, what has happened is, two things happened. One, the size of tumors then used to be the size of an apple or an orange. Now it has become the size of a pepper or a peanut. Okay? So in 20-30 years, you can see that dramatic shift first. But it also brought about something very new, which we never realized at that time. We picked up a lot of things which we have to name it as cancer, but they don't actually behave like a cancer. You can carry on living with this kind of a problem without it affecting you ever. So that's the reason why I say in the same name there is so much of complexity involved that one can never pick up a kind of test and say that this is the way to go. We may. What is the example? There was a paper which was much spoken about 2 years ago. No, actually last year. They said with the blood test we are able to figure out some 12 cancers. All right, you give a blood test, you are going to figure out what happened to it. No approval in any kind of health authority yet, and it can never be reproduced as yet. So there is, because of lots of complexity, we are unable to give you a single test to tell you, okay, whether you have a cancer or not, and if the cancer was there, where it is located. So we have lots and lots of things like circulating tumor cells and exosomes and things that we are researching, but it's not to the practical use level at this point in time. The second question is about environmental influences causing a rise in cancer. Yes, it is. So we have shown this in a preventive strategy in a lot of areas. Say for example, there was a point in time when dyeing industry was involved with a lot of bladder cancers. Once we got all this pollution out, you don't have so many bladder cancers related to that. Within doctors, we know exposure to radiation is not good. You see cardiologists, you see orthopedists all the time working under the X-ray machine, the radiologists all the time working under the X-ray machine. And now they all have this sievert counter, and then they have the protective gears, and then they move about it. So we know that environment does increase the incidence of cancer, and preventive strategies do work. Please.
See, some of the drugs which are banned in US are being widely used in India. Is there any standard and code? For example, Librax is very widely given for stress related to IBS, but if you browse the net, it is clearly stated that it is banned in US. Even Flunarin, which is given for migraine, which is banned in US. Why it is being used in India? And one more question, will the drug interaction will lead to cancer? For example, the anticoagulants which you give, the blood thinners for heart, people. Of course, the awareness has been created and life expectancy has been increased in case of diabetic patients and heart patients we are treating. But the blood thinners, it leads to liver hemorrhage, and will that lead to liver cancer? That's my concern.
Okay. So, if you looked at any of these labels of a medicine, you will have always information in that saying toxicology test done, that includes carcinogenicity,
Yes,
mutagenicity.
So it is carcinogenic and it's been found in rats.
Right.
They do that test,
Exactly.
right?
Exactly.
But
So
why it's still being used in India and they give?
see, what I am trying to tell you is any chemical that you introduce into a biological system will have a side effect. Whether if the side effect incidence and frequency is acceptable enough in terms of balancing it with its benefits is a question. Let us say we are able to prevent 100,000 deaths because of strokes and heart attacks by using blood thinners, wherein one person had cancer related to that. Would we ban that drug? So, that is the question. So, if I can save 100,000 people in the process of, the same thing happens in vaccine, it becomes a very emotional thing when it comes to children. Vaccines do cause death, but they are so far infrequent. We saved many millions of children to grow into their adulthood, while we just lost one or two very rare ones. So, should we ban that vaccine? That is keeps coming up this question. And in the terms of drug interaction, like I told you, any kind of, see, is food a chemical or not? Can we go away without food? What? You look at colonic cancers. What is the reason for colonic cancers that the Westerners have so much and now we are trying to catch up with them? It's because of the amount of fat we take in. So, is it not food that forms part of it? Why is Chennai leading the, of all cancers, Chennai is the one which has the highest stomach cancer in men? Why? The entire world has only lung cancer. But in Chennai, we have stomach cancer as the highest. Why? Because we are so used to spice. So, can we change that? It's food. So, regardless of what you call it as food, medicine, chemical, pollution, Chicago has now put up with some biosensors within a community. The entire city is put up with some biosensors to measure the level of air pollution, noise pollution, whatnot, and trying to see what the trajectory of illness in that community is, and whether if they can change things for that community. So, when people we are studying, but it is not something which can be completely eliminated, and we can never become immortal. We have to accept mortality, we have to accept certain imperfections, but within certain limits of what we should be able to accomplish.
Is there any method to prevent, like while taking blood thinners, we can do simultaneously periodical checkup whether there is a development of cancer or not?
Not that I know of. Sorry.
Thank you. One last, since I have already committed. Yep.
Quickly, this isn't a medical question as much as the morality and the ethics of what you want to do. I just read an article on CRISPR.
Yeah.
So, what's your take on CRISPR? Where does it end? Where does it start? Do you see some ethical boundaries that are being drawn? What's the regulation around that?
Yeah.
Because it seems to be.
Okay. I think the pinnacle of this question is, can we have designer babies? That's what you're asking, isn't it? So, it started even at Hitler's time. He had started the program of eugenics, isn't it? He just wanted to eliminate who he thought was genetically inferior and keep only people who are genetically superior. We are coming back in a different way through the route of CRISPR-Cas9. And that again goes on to say, in the society and the morality of the society, you have to keep pace with all the imperfections that is there, and that is part of normal living, no matter what. So, even with CRISPR-Cas9, can you ever say that designer baby would always be what it was? See, this goes back to Immanuel Kant, the philosopher that I am totally floored of. Okay? Immanuel Kant gave this thing about what are we talking about epistemologically? Are we talking about an a priori or is it an a posteriori type of approach in life? He says, if you are all born like a wax block, and it was time and experiences which is shaping you into the human being you are, then it is completely a posteriori. But suppose I say you come like a software program and you just unleash through your life whatever you are programmed with, and then just die a natural death. It's called a priori. And where are we? Are we in this a priori or in the a posteriori? We are somewhere in between. And so just by creating a designer baby, I don't think we are going to achieve exactly this kind of society in its paradise, isn't it? Yeah.
Thank you. Thank you, everyone. As a token of small appreciation, may I invite Sumati to felicitate Dr. C.S. Mani. Thank you. Next question. Usefulness of the information presented. Thank you. Third question. Quality. Fourth one. And the final.